So I want to talk about something. I actually quit my practice to do this. We had a great team. We were having great results. I was enjoying teaching the fellows. And this is the reason why I quit my practice, was for this reason, is that once you understand the true nature of chronic pain, which is defined as a neurological disorder, it changes the game. If you don't have the correct diagnosis, you can't treat it properly. Less than 20% of physicians are comfortable managing chronic pain. Less than 1% enjoy it. That's across every specialty, even pain specialist. And as surgeons, we just dread chronic pain, including myself historically. So I was in chronic pain myself for 15 solid years. That's how this book evolved. I had no idea what hit me. I had no idea it came out of it. Then the last 5 years of neuroscience research has made it incredibly clear what the problem actually is. So it turns out there's a lot of spine surgery being done on a neurological disorder, anxiety. And you all know the success rate of lots of surgeries aren't great. So we put a process in place. We watch hundreds of patients go to pain-free. And we're watching lots of surgeons. And this group, of course, says one reason you're good surgeons, which is a little unfortunate for the patient, that we end up taking care of lots of problems created by people on the outside. When we look back at the films, that first surgery never should have been done. So we realized that we put a prehab process in place to optimize our outcomes. And then we did good rehab afterwards, even with these surgical disasters. So you'll come out of here with a very high level of technical skills, but a lot of, when you look back at the patients and look at their suffering that was needless, it's really tragic. So I thought I'd quit my practice to do this, and it's a new set of symptoms. New experience for me. But it was actually easier to do spine surgery than it is to be in this world selling a concept. Because in surgery you have some control. When you're selling an idea, people can reject it or accept it. There's actually more anxiety in sales than there is in being a surgeon. It's a different anxiety, but it's there. So the term came up around 2002 called medically unexplained symptoms. And what it means is a little different variation on, quote, psychosomatic. Psychosomatic implies that the symptoms aren't really there, or you're there, or your wimp can't tolerate them. The term really means, well, we know you have symptoms. We don't know the cause exactly. There's really nothing we can do, so have a good life. So it's a step further in actually moving the process along, except it takes away hope. And we find out that taking away hope has been shown in research to actually increase inflammatory markers. It is a deadly diagnosis. So the purpose of this talk is to let you know that there is always, I use the word always in big letters, that there's always an explanation for symptoms. This goes back to high school, college, and medical school physiology. So the research shows in back pain that we know the exact source of pain from a structural standpoint anywhere from 5 to 15% of the time. Infection, tumor, ruptured disc, et cetera. And there's congenital reasons, enzyme deficiencies, et cetera, that create problems. And then physiology is a reason for the vast majority of the symptoms in the body. Now, why is that? Because we are alive. One of my mentors taught me that, what's the difference between a cadaver and a living human being? Think about it. The structure's still there, but it's the energy. There's a quantum physics model of cell biology now that's becoming more and more apparent. And it's the interaction between your positive and negative charges on the proteins that creates life. ATP to ADP, that creates life. It's a living organism. The human body has 30 trillion cells. 50% of the brain is glial cells, 50% is neurons. There are 80 billion neurons in the body. Each neuron is connected to 10,000 other neurons. It's complicated. So think about a Boeing jet. This has 2 million parts. Your computer is taking in sensory input, making decisions for the plane to fly with a little bit of pilot control, but this jet cannot fly without a computer. Your human body, which is 30 trillion cells, is not going to function without a nervous system. So it's incredibly complicated, it's intertwined, it is just a unit. So I do not like the word mind-body anymore, because it implies there's a separation in the first place, and it is not. Then human consciousness really has been around for about 100,000 years compared to 14 billion years of the Big Bang. So human consciousness is new, and it causes a lot of troubles. Think about your cat or your dog. It stays alive, knows how to hunt, knows how to take care of itself. You get a feral cat versus a domestic cat. They learn to process their environment and stay alive. They don't have language. Their bodies know how to stay alive based on avoiding threats and gravitating towards safety. So humans are the same thing. Most of our unconscious brain keeps us alive. My pupils dilate, constrict, my mouth is moving, but I'm not thinking about it. It's automatic. And the nociceptive system, by the way, I had it backwards. When you stub your toe, you think that's nociceptive pain. Wrong. The nociceptive system guides you in a manner that you don't feel pain. So when you actually feel pain, your automatic nociceptive system has, quote, failed, or you've exceeded it, so you go back into a safe zone. That's nociceptive pain. It keeps you safe. The unconscious brain processes about 20 million bits of information per second. Digestion, acid-base balance, et cetera. The conscious brain processes 40, 20 million versus 40. So it's not responsive to rational interventions. So what the consciousness does, though, if you look at this dragster, it takes a parachute to stop it. It has 11,000 horsepower. And trying to control your unconscious brain with your conscious brain is like trying to stop this dragster with bicycle handbrakes. You can't do it. But what consciousness does, it does give you the steering wheel. You can direct it whatever way you want. So I started a movement called dynamic healing, is that we are acknowledging our environment right now. We're pretty safe. We're comfortable. Temperature's okay. That's our sensory input. It's processed by the central nervous system through all the different sensors. You have an output that's either safe or neutral, homeostasis, or threat. All three are necessary. None of them are going to go away, but your body's physiological state actually determines your psychological state. So it turns out that you have all this input. Interoception is the input from your gut, bladder, et cetera, your internal organs. But it turns out that thoughts and emotions are processed in the same part of the brain as a physical threat. Same part of the brain, same chemical response. And it's, again, I call it the junction box. The autonomic nervous system, central nervous system, neocortex, spinal cord, peripheral nerves is all part of one system. So the output's going to be either pleasant, safety, neutral, homeostasis, or unpleasant. So let's go to threat, because that's where disease comes from. Is that threat can be physical, or it can be mental. Humans have a major problem that we cannot escape our thoughts. We all know that. When we try not to think about something, you think about it more. When you think about something, you actually think about it less. And I'm putting on a workshop next Saturday, by the way, that deals with that exact problem with human cognition, because it's sort of the essence of human misery are these unpleasant thoughts that we can't get rid of. And it turns out that the more of a well-intentioned person you are, the worse the problem by far. Poorly intentioned people don't have a lot of positive thoughts, so they actually have a competitive advantage not being burdened by what's called the seed of our undoing. Different topic. But we can't escape our thoughts, and what happens is that it comes in the nervous system. You have sustained threat physiology. So we need threat physiology to survive, but we're not intended to be in sustained threat physiology. So in threat, you have a quick response, or if it's a little bit longer, you might develop symptoms like a cold or a headache or something like that. And with sustained, people get sick. That's been known for many years. This is the Holmes-Rahe scale out of the University of Washington, published in the 1960s. And they rank all these different events in life. 2/3 of them are negative, but some are positive, new job, marriage, et cetera. So there's a point scale, points awarded to each event. If you hit 300 points, you have an 80% chance of a serious illness within 2 years. This is in the 1960s. This has come off a website called The Stress. So people get sick, but why? Why do they get sick? I mean, autoimmune disorders, cancers, all these different things are the immune system. And what I forgot about before I went into this process a little bit deeper is that part of the threat response is your immune system. And you have these white blood cells chewing up the inside of your arteries. Cardiovascular disease, hypertension, peripheral vascular disease are all inflammatory disorders. So is anxiety, depression, and Parkinson's and Alzheimer's. You have these inflammatory cells chewing up your body. So then let's look at the nervous system. So remember, we have the input, your stresses. Then you have your actual nervous system, how you process it. And if you come from a chaotic background, I think most of you have heard of the ACE scores, Adverse Childhood Experiences, a major Kaiser study, that if you have a score of 5 or more on a 10-point scale, you have a 7-year shorter lifespan, double heart disease, diabetes, suicide, anxiety, and depression, and it's a disaster. So why is that? So if you come from a nurturing family, it's like driving it looks like your brain is a Ferrari. You handle stress, you handle the curves, you just keep cruising through. So you have a resilient, good nervous system compared to this. So I did come from a very abusive background, and this is what I was driving, and I put a big engine in it. I mean, I got to be a spine surgeon. In Minneapolis, it was not a small level fellowship at the time, still isn't. And I did it. But at age 37 years old, I went from being a fearless surgeon to a full-blown panic attack and started a 15-year tailspin into a burnout that was just brutal. So the resilience of your nervous system is determined right now. All of us are programmed by our past. If you come from a chaotic, dangerous past, anytime you're anxious or frustrated, something in the present taught you something in the past that was dangerous. So you don't put your hand over a hot stove because you've learned in the past that a hot stove is dangerous. Same thing with somebody who's your childhood bully. If you walk into them on the street, guess what? Your body's going to react. Now, you might be safe now, but your body doesn't know that. So your unconscious brain is going to protect you. So there's the input, your circumstances. There's the status of your nervous system. It's either calm or hypervigilant or hyperreactive. And then you have the chemical output, which is either threat physiology, neutral, or safe. So again, threat physiology. You have inflammatory cytokines, your cortisol is up, your metabolism is up. We think that Alzheimer's is the body cannibalizing its own neurons based on sustained threat physiology. A lot of data behind that. So what happens, since you can't escape your thoughts, a lot of us spend your time like this. Now, I'll tell you in medicine, when you again understand this whole process called the seed of our undoing, the more of a well-intentioned person you are, the worse problem we have with this phenomenon. So again, the workshop's next Saturday. It's on my website. It's a one-day workshop that I'm very excited about. And just take a look at that and just consider joining me on that one. So is your brain like that, or is it like this? So you need threat to survive as necessary. The word we use to describe that state is anxiety. You're lying on the beach in the sun, you are relaxed, you've described your physiology. If you're being yelled at by your mentor or your spouse or whatever, your body is reacting, including your immune system, and you're agitated, that word is called anxiety. Anxiety is a result of threats, it's not the cause. And since it's part of this neurologic survival response, it's 20 million bits of information per second compared to 40. It is not subject to rational interventions. So under sustained threat physiology, you develop all sorts of symptoms. So let me just give you one example of among probably 30 variables. We'll just touch on one right now. There's a paper out of Israel, 4-year prospective study, that showed insomnia actually caused chronic low back pain. Caused it. In the last sentence of this paper says that we did not find the reverse causation. So in my spine training, did I ask my patients if they were sleeping? No. There's a bigger factor predicting disability with lack of sleep than there is with pain. One night of sleep, one night of poor sleep increases your pain by 50% the next day. So it turns out, again, clear down to the genomic mitochondrial level, there's a common basis for all chronic physical and mental disease. So cancer, diabetes, atherosclerosis, depression, osteoporosis, asthma, this is not casual research. It's been around for over 30 years. The last 10 years have been unbelievable. And we have a think tank that meets once or twice a month now for an hour with the top neuroscientists in the world discussing these concepts, and we're just blown away. We are blown away. So what happens, you have a nervous system or your body. Again, the nervous system is completely entwined with every cell in your body and vice versa, so there's no separation. Your body's fired up. So what happens, and I had 17 of these symptoms, by the way. So I had migraines, ringing in my ears, burning feet, anxiety, panic attacks. Again, that's a dysregulated nervous system. That's not psychological. Your body gets adrenaline, cortisol, your heart races, etc. My heart would pound at night. My wife still asked me to start scratching my scalp because that was an itching scalp thing. Skin rashes would pop up on my wrist. I had no idea what was going on. Those symptoms are all gone, every one of them, unless I quit practicing my tools. So what happens if you're doing, we're very focused on structural interventions in medicine in general. And again, probably 90% of symptoms are based on physiology. The interaction between your environment, when your environmental circumstances overwhelm your coping capacity, you're going to go into threat physiology, period. Your body has to do that. So for instance, I'm not going to spend a lot of time on this, but there's one research paper. The success rate of a back fusion for back pain, just based on disc degeneration, is about 20 to 30%. The literature clearly shows that arthritis, bone spurs, arthrosis, degenerated disc, bulging disc are not the source of pain. They are not. Yet it's one of the most common things we do is do infusions for back pain. Look at this thing. It doesn't move. It doesn't move. It's stiff. Remember, we looked at the first slide about the dynamic brain. So there's a paper back in the 1950s in JBGS that showed that people had less back pain after discectomy if the disc base collapsed and didn't move. So we look at disc degeneration, and we all know you take those flat discs at 5-1, sometimes 4-5, and somehow we have to fuse those things. The pain isn't coming from the static structure. It's coming from your interpretation of the entire environment. Just a quick example, my son used to be a sales rep in spine for about 3 years. He's a top-level competitive mogul skier. He developed severe back pain for 3 solid years. The day he quit his job, back pain's gone. Been gone for 3 years. So he loved his job. It was very stressful. Trying to raise kids, et cetera, with a sales rep's life was really tough. Back pain's gone. Talked to him a couple days ago. I was head of the Scoliosis Research Society non-operative committee a couple years ago. We put together a work group of 50 physicians and psychologists, and we looked at the literature on what are the indications for doing scoliosis in the adult population. They are not there. There's not one paper that says, compared to non-operative care, this has a curve of 30, 40, 50 degrees causes pain. There's no data. So we had one work group looking at that. Then we wanted to know if the basis for doing surgery is failure of non-operative care, define the care. No definition. None of the papers talked about what was done before surgery. Let's just take sleep. I mean, why would you do a 10-hour surgery on somebody without making sure that they're sleeping first? We call it prehab. So there's nothing that says that this spine hurts. Indeed, this is a woman who I worked with for a couple years, went to pain-free in about 2 years. What I didn't know until a couple years ago, that there's quite a few papers that talk about if somebody is in chronic pain, I thought that you should do surgery faster for structural problem, not later. The data says the opposite. You can actually induce or make chronic pain worse as a result of surgery in a fired up nervous system. Any surgical procedure can induce or make chronic pain worse. You already have a fired up neurological problem, you start plugging in body parts, it's a big problem. So the process of dynamic healing acknowledges the circumstances, acknowledges the person's coping skills. That's the cause. Medicine's treating only symptoms, which is important, but unless you actually deal with that dynamic interaction between your circumstances and the person's coping skills, you might as well be trying to be putting an oil well fire out with the garden hose. You're not going to the root cause. Don't try to read this slide. Just notice that there's on the left side is the different inputs, the one nervous system, and then the chemical state. Then the different interventions that we do are focused on all 3 parts of these things, and there's never one intervention that works. There's always a combination. So what are we doing? There's a paper done in 2014 out of Baltimore showing that only 10% of neurosurgeons and orthopedic spine surgeons are doing pre-screening and treatment before they do surgery, 10%. And the community surgeons are actually a little bit better than the university surgeons in doing this, 10%. So I used to tell my patients, why would you want me to cut your success rate in half by not doing things that are going to optimize your surgical outcomes? So without going a lot into the solutions, it's a solvable problem. We had wonderful surgical results when we did the surgery. I'm not against surgery. So I wrote this book called Back in Control. You can look it up at backincontrol.com, and that's my personal email. You can get it from anybody here. I wrote another book in 2019 that Jens and I have talked about for a long time. It takes surgical decision-making based on the anatomy and the state of the nervous system. We have 1A, 1B, 2A, 2B. So it takes that clinical care model and puts the decision-making into one of 4 quadrants. So it's a great book for you as a fellow right now to really clarify the decisions whether to do surgery or not. It helps the patients also decide to do surgery. Also primary care physicians and physical therapists can, sorry about that, I'm done. So it's really a quick read. And what's happening now, and I can't believe I got into this, so I'm essentially rewriting my book, because what I just told you today is the foundations in back and control, but the neurophysiology over the last couple of years just blows me away. So this is called the DOC Journey. It's a self-directed process. It is a subscription, $25 a month, and we're seeing people getting better within 6 to 12 weeks, way faster than we thought. I'm clearer than I used to be. Hopefully I'm clear this morning. And again, in summary, you have your life, you have your coping skills, you have the state of your body's chemistry. The goal is to give you the tools, not to fix yourself, but give you tools to be able to deal with adversity in a very quick, proactive way. So you want to minimize your time in threat physiology. You're never going to make something bad be good. That's not the goal. But you develop a working relationship with this threat response that we call anxiety. So for burnout, huge implications, especially this group of very well-intentioned, hardworking people. This is a bigger problem than somebody who's just doing assembly line work. It's a huge problem in this room. So this is a baby of a woman I treated in 2013. I didn't treat, she treated herself. 4 years of chronic pain in New York. 6 epidural injections, facet blocks, high-dose narcotics, saw 10 physicians, and in 2 weeks she was pain-free by using the tools that we're talking about. So she's now married, 2 beautiful kids, and it happened in about a week after 4 years of trying everything. It's a self-directed process. It's been the most rewarding phase of my career, and I loved my practice. We had a great time. So I truly miss you guys, no question about it. And I've learned to, I learned to take the abuse of the world better because of you guys, so thank you for that. But yeah, I really miss this process. It really bothers me in a way that there's such a need to do this. I really did not want to give up my practice, but I just felt compelled to do this. Thank you.
Outstanding, Dave. Thank you. As much as it looks like a hopscotch of themes, it's so important to kind of, through the diversity of themes, keep everybody alive and running. So a couple of thoughts. So in our everyday practices, how should we screen for mental illness? Should we use, the multi-phasic inventory test is over now, but how should we screen for that? Are there some magic questions? Should we use a structured inventory like the Beck's Depression Score? What should we do?
So I've changed to a very generic approach. I don't think screening questionnaires help that much, because if you're in chronic pain enough to start talking to a surgeon, you're not very happy. And people that put themselves at stage 0 on anxiety, depression, and irritability, when asked a simple question, well, what about the pain? They just explode. They pisses them off. So I just do prehab on everybody, just simply put them through the process, calm them down, optimize them. Some people don't need it very much. So all of us, correct me if I'm wrong, does anybody in this room not have some anxiety in life? It's part of the human experience. So as you just teach people to process, it's a great stress management approach. And again, it's not, actually, the other thing I do with this process is really critical, is people have been bounced around, they're frustrated, and they have a lot of cynicism. Why would this work? So it's not about believing the doc journey, it's not about believing David Hanscom, it's about digging into your skepticism. Going, what the heck? That's where you start. What is real? And so once you starting there, that's what the doc journey does. It goes through a sequence of digging in, then people start to come out the other side.
2 other quick questions. Thanks for your short answers. Fibromyalgia. Certain conditions just kind of really invoke, very pertinent to the MUS theme, a very kind of high degree of anxiety in myself. Should we just not treat those patients surgically?
Well, I hate to sound like a salesman because I really do hate this part of my job, but the DOC journey has been extremely helpful. It's a self-directed, 90% of it is self-directed, so I love fibromyalgia. The problem with fibromyalgia, now Ehlers-Danlos, and these other different syndromes, is that people get attached to the diagnosis, and the number one factor that determines success is whether they're willing to engage. So if they have this injury conviction, they're in this really sustained threat physiology, and as my friend D.R. Clausen points out, they're offline. In other words, the brain's away from the neocortex. You have an inflammatory response in the brain, and they don't think clearly. So if you can get that type of patient to engage, it's game on. They do great. So fibromyalgia is one of my favorite diagnoses if I can get them to engage.
Final question, common American theme these days, the iatrogenically and legislatively created opiate crisis. Should we prehab patients by getting the opiate load down?
So the solution to chronic pain is three things. You become aware of the problem and the nature of the solutions. You treat every aspect simultaneously, which includes the opioids. But the third part, the patient has to take control. Each person looks at their own life through their own eyes, and I don't know you. I can spend hours with you and not solve your life. So what causes the opioid crisis, and by the way, 40% of my entire surgical practice was with infected spines. So in the hospital for 6 weeks, so I get to know these people really well. What drives the opioid crisis is the mental pain. So if there's another message I'd just like to leave you with is that the mental pain is a much bigger problem than the physical pain, and people can't escape it. They're tortured by it. The opioids actually work. It actually solves mental pain. But obviously not a good one. But yeah, once people actually go to the root cause of the stresses versus their coping skills, then the opioids start to disappear.
A common friend of ours taught us a great line, which I've always applied since then. Pain is a fact of life, suffering is optional.
Absolutely, right. So that's a good, wonderful ending point because, okay, there's pain, mental and physical, it's there, but it's that chemical reaction to it is where the suffering comes in place. So what you're training your body to do is to auto-regulate your body's physiology. You can't control your thoughts, you can't control much of your circumstances, but you have a huge say about how you deal with the physiology. So that's a wonderful last comment.
Great commentary, great lecture. Thank you, Dave.
Thank you. All right.